Good afternoon, everyone. My name is Annie Ganguly. I'm the Champion Support Manager for the network. And thank you for your time this afternoon for this webinar. We have taken this opportunity to initiate and launch our Lunch and Learn webinar dedicated to advancing the understanding and dialogue around the portfolio of reproductive health and pregnancy, childbirth through a research-focused lens, with more speakers being invited to shape its topics and themes. We are continuing to welcome more submissions from researchers, clinicians, midwives, students, educators. We have quite a few people registered for the webinar today. It is sharp 12 o'clock, so I will get going because we've got two guest speakers and we've got our chair, Dr. Black, as well, who I will introduce in just a minute. All of you are on mute with cameras off, and just for housekeeping purposes, this meeting is going to be recorded and will be archived. You can sign up for any future webinars through emailing myself, and you can obviously let us know what you would like to be featured in those webinars. As I said, cameras will be off while the speaker is talking, but if you do have a question, please raise your hand or leave a comment and I can take you off the mute button. Q&As will be taken at the end of each talk as well. I will start up with a quick research roundup where one of the key pieces of news is that the reproductive health childbirth specialty is looking for a new clinical lead. The closing date for this position is the 20th of March. You can see the name and the details on the screen as well. This was also sent out in our newsletter, and if you need any more information, please do feel free to get in touch with me. Today's chair for the webinar is Dr. Myreed Black, who most of you may very well know. She is a clinical academic obstetrician who aims to improve women and childbirth's experience and outcome. She provides leadership in the advancement and delivery of maternity care, pushing very high quality care and support for pregnant women. Dr. Black is also an honorary consultant obstetrician at Aberdeen Maternity Hospital with leadership roles in labor ward, quality risk and governance. She is also the academic lead for Aberdeen Maternity Neonatal Data Bank and co-leads the Aberdeen Clinical Academic Training Pathway. So Dr. Black is our chair for this webinar, and I'm going to end up with some of the events coming up as well. As you can see, the Patient and Public Involvement event is in Stirling Court Hotel on the 3rd of March. There is the Scottish Preconception Health Research Showcase on the 26th of March at the same venue. And we also have the 11th Grampian Conference collaborated with our portfolio with the theme of better cancer outcomes on the 14th and 15th of May, which is Thursday and half day Friday. And the program and registration for these events will be on the NRS website. So with that, I am going to give the flag to Dr. Black.
Thank you very much, Annie. I'm delighted to be hosting today and to introduce our two speakers. So first of all, Professor Suzanne Hagen, who's based very much in the west of Scotland, a statistician by background, who has been researching continence since 1995, directing a pelvic health programme at Glasgow Caledonian University since 96. And most of Prof. Hagen's work is on non-surgical management of prolapse and bladder issues, with lots of different research methodologies adopted and various studies influencing national and international guidelines. So we look forward to hearing from Prof. Hagen about the PEPPY study. And I'll also introduce Dr. Margaret Taylor, who is a consultant radiographer and sonographer at NHS Tayside and has recently completed a professional doctorate on understanding adenomyosis and delays in diagnosis, with 3 publications already. So this is great timing to be hearing about the work. And Dr. Taylor has also been highly commended in the 2025 Society of Radiographers Scottish Professional of the Year, and this reflects her commitment to leading service innovation projects with a big focus on redesigning services to be more patient-centred. So thank you very much for joining us today, and I will invite Prof. Hagen forward to tell us about the PEPPY trial. We have about 20 to 25 minutes and a few minutes for Q&A at the end. So Go ahead, Prof. Hagen. Thank you.
Thank you. Okay, thank you so much for inviting me. It's a real pleasure to speak to you all today. And I'm going to talk about an ongoing trial called PEPPY, which is a multi-centred randomised control trial led by myself based in Glasgow Caledonian University. So I'll tell you all about the trial today. Hopefully you'll find that interesting. I'll firstly give you a quick introduction to the team. So there's myself as the chief investigator. Carol Buge is the co-chief investigator and leads on the more qualitative parts that go alongside the trial. And you can see our list of trial investigators there, including, very importantly, our PPI members and clinical colleagues. We've got a lovely research team, Katrina and Lynn, based here at the trial office, Mel, also qualitative researcher, health economist, Sarkis, and Kath Best is our statistician at Stirling. So a nice team. We've worked together quite frequently before and doing so very successfully. So what I hope to do just over the next wee while is give you some background to where the trial came from and talk about the research questions specifically and the methods, look at how the trial is running practically at the moment, and then give you an update on the progress where we're at. So for you who don't know much about prolapse, what is it? You can see the little diagrams here on the right hand side showing you some different types of prolapse, but essentially it's the descent of parts of the vaginal wall, the anterior or the posterior wall, or the uterus or vaginal wall itself into the vagina. And it comes with obviously quite distressing symptoms associated with it. And it's a common condition, probably more common than people realise. So if women were examined, 30 to 40% of women would have prolapse on examination, and 5 to 10% would be reporting symptoms along with that. Almost 10% would have prolapse surgery across their lifetime. And the types of treatment are mainly three: surgical, as I just mentioned there, PessarY support device, which you can see a little picture of there in the middle, one of the types of PessarY that's available, and also pelvic floor muscle training, which is usually taught by a specialist physiotherapist. And the sort of cornerstone of the research we've done over the last probably 20 years relates to pelvic floor muscle training and looking at its effectiveness. And we did one of the main trials that developed the evidence base for pelvic floor muscle training for prolapse. And the work that I'm talking about today really follows on from that. So what is the research question? Well, we want to know whether if women have supervised pelvic floor muscle training plus a vaginal PessarY, whether that's more effective and cost effective than having supervised pelvic floor muscle training alone. This is for women who've got prolapse, and we're measuring their symptoms at 12 months. So this is where the PEPPY acronym has come from. And why did we come up with this question? Well, both PFMT and PessarYs are used in the treatment and management of prolapse, and they're also used more frequently together. That's been a progression in practice, I think, over the last few years. So we were seeing it happening in practice. We did a survey of women's health physiotherapists, and certainly there was evidence that PessarYs and PFMT were being used together. There was also a sort of impetus for the research coming from NICE guidelines and from the James Lind Alliance, who identified that we needed evidence to support this type of combined treatment. So we identified this as an evidence gap. Because it was mentioned in a NICE guideline, we were able to apply for funding from NIHR through their rolling programme for NICE guideline questions, if you like, questions that arise from NICE guidelines. And this was our sort of proposed hypothesis for the possible benefit for this combined intervention. And we've got our proposed programme theory here, thanks to Carol, my lovely colleague Carol, developing this nice programme theory. So the hypothesis that by supporting the women's prolapsing organs using a PessarY, that the pelvic floor muscles then can be trained more effectively, and that in theory would lead to better treatment outcomes than if they had pelvic floor muscle training alone. So that's what you can see represented in this organisation, or sort of the programme theory diagram here. This chart really gives you an overview of the research as a whole. What you see in the middle of the blue section is the trial at the centre, and you can see the flow of women through the trial from being invited and screened to starting their pelvic floor muscle training, being randomised to one of the two groups, and then they have follow-up outcomes measured at 6 and 12 months. And on both sides of the main trial, you can see the process evaluation elements of the research, whereby we're doing more qualitative work, trying to understand the context in which the trial is running, women's fidelity to the interventions and their acceptance of it. So that's a really important part of the research that's supporting what's going on in the trial itself. The population that we're interested in, quite sort of straightforwardly, is it's women who are having pelvic floor muscle training for prolapse. So these are women who have chosen PFMT, been referred for PFMT for prolapse, and what we want to do then is to randomise them at that point. And the prolapse can be of any severity and any type, and even if they've had previous prolapse treatment before, then that's not an exclusion, and it's women aged 18 years and over. The prolapse should be their main presenting problem. They can't currently be using a PessarY. If they are, they would have to discontinue it for a month. No women who are pregnant or less than 6 months postnatal, or women having active treatment for cancer. Those women who've got severe vulval disease or have a cognitive impairment which would impair their ability to give informed consent. So the trial interventions themselves, what we're randomising women to is either supervised PFMT alone or supervised PFMT plus a PessarY, and we're aiming for 276 women in each of those two groups. I'll go on to give a bit more detail about the ins and outs of the intervention. So firstly, this slide covers what happens within the supervised PFMT, and of course this applies to both trial groups because all women will receive the PFMT programme. And what it consists of is 5 appointments over 16 weeks, with 3 of these appointments being face-to-face. 2 of them can be delivered virtually or over the phone. And this is a protocol that we'd used in our previous trial, which we found to be effective. And the content of the intervention, the appointment would obviously be tailored to the woman, and it would be based on the physiotherapist's usual practice. We do suggest spacing of the appointments, which is not always possible within the structures of the NHS services, but we try to suggest that closer together appointments to begin with and then more spread out is a good way to support women. So within the appointments themselves, the physiotherapist would be teaching the pelvic floor anatomy, and we provide the centres with model pelvises to use for that purpose. They assess the pelvic floor muscles and they teach the correct contraction of the muscles and the NAC technique, and then they provide an exercise home programme working towards 10 times 10 long holds and 50 up to 50 fast contractions 3 times a day. And then they record what they do within that appointment over in this form that you can see in the right hand side. We've developed some aspects of the intervention as the trials began. Initially, we didn't allow any of the sort of adjuncts you might expect with pelvic floor muscle training, so like the EMG biofeedback or electrical stimulation. But having consulted through the pilot, that those different adjuncts are now eligible because those are what would be offered in routine practice. So we've incorporated them in. If that's clinically indicated, then those interventions can be provided to women also. And the women are asked to complete a diary booklet, which they're given at their first appointment, and they record their pelvic floor muscle exercises they do over the next 7 days after that appointment, and similarly after each of the appointments that they have. And then they can return that diary to the physio when they come back. So then just moving on to the additional bits then that the women get if they are in the PFMT plus the PessarY group, as well as the PFMT programme described previously. At their first PFMT appointment, they would have a PessarY fitted, or if not, that's not possible, within 2 weeks. If they, for example, have to go to see maybe a consultant or a PessarY nurse to have that done, then it's done within 2 weeks. And the PessarY type that's fitted is really whatever's clinically indicated. So there's no restriction on what type of PessarY, just whatever's clinically indicated and fitting in with the pathway of care that's at the centre. The women can self-manage the PessarY if that's an option for them being taught that at their centre. And the women are encouraged to use the PessarY for a minimum of 16 weeks while they're receiving the pelvic floor muscle training, but they're free to use it beyond that time period as well. The women are asked to remove their PessarY or have it removed 2 weeks before they receive their 6 and 12-month questionnaires, so that their responses reflect how their symptoms are without the PessarY support. And if they're self-managing, then that's obviously they can remove the PessarY themselves. If they're having follow-up care within the hospital and within the clinic environment, then that's something that we would arrange. The women also complete the diary, and as well as information about their pelvic floor muscle exercises, they'll also record information about how they use their PessarY over the 7 days following the appointment. So data collection, let me move on to this now. We've got quite a battery of outcome measures that we use within the trial. The primary outcome is the PFDI-20, which measures pelvic floor dysfunction symptoms, and we measure that at baseline 6 to 12 months. And then you see the list of secondary outcomes, further questionnaires covering quality of life, sexual function, other treatment that women might have had offered or sought, self-efficacy, and we look at intervention adherence through the diaries. The pelvic floor muscle strength and their prolapse severity is recorded again at a 12-month assessment, which I'll say a bit more about in a moment. The economic outcomes, they are given the EQ5D, 5L questionnaire to complete at all the 3 time points. These are mainly questionnaire-based, baseline 6 and 12 months. Women can have these questionnaires electronically or in paper, whichever they prefer, and they're given a £10 voucher when they complete their 12-month questionnaire. Diaries, as I've mentioned, is used to measure their exercise and PessarY use, and then they have a pelvic floor muscle assessment at 12 months where they're brought back to clinic for the purposes of that. A bit on the process evaluation data, which is my colleague Carol's area of expertise. So these are the 5 main strands of data collected in this part of the research. So there's some audio recordings of the pelvic floor muscle training appointments, 25 in each of the groups, to get information about the delivery of the intervention. We've got interviews with 30 women, both at baseline and then again at 12 months, 15 of those in each of the groups to get their perspective on the trial. Interviews with staff, 26 of those. There's a question in the questionnaires that women are asked to complete, which is an open-ended question asking them again about their experience of the trial. And we also collect something called the NOMAD tool, in staff members that are recruiting at the different centres. So I'll just say a wee bit more about that. This is basically about looking at the implementation of this as a new intervention that maybe staff are not familiar with at centres. So we're trying to get the perspectives of the staff who are working directly with the intervention about how this complex intervention is being implemented. So the staff at the centres who are delivering or running the services are asked to complete this twice before the trial starts and then at the end of the intervention delivery at the centre. The trial works basically through our CTU, which is the CHART CTU, which is based in Aberdeen University. We've worked with over all our trials, and they have a data management randomisation system set up for us, which works beautifully and gives access to us here at the trial office and to the centres who are involved in recruiting. And they're able to do all their data entry, randomisation, and have access to the site investigator file on there all in one place. Just gives you little screenshots of what it looks like. As I say, they can access the site investigator file. There are any updated documents that come around as the trial progresses would be in there, and they're also given a sort of a hard copy or a folder version of the site file as well, which they can use. So we try to be as flexible as possible for the centres. Another element of flexibility is we've built in both e-consent and paper consent for the women. This just gives you an overview of that process. So women are asked at the start how they want to proceed in terms of consent. And it gives that extra element of flexibility for us. So just to coming to the end of the presentation, I suppose it's just to start to give you a bit of an overview of where we're at with the trial at the moment. So the trial officially started in November 2024 with the plan that we would start a pilot trial in May 2025. So our target initially we were looking at 13 centres. We're probably going to have more than 15 now, with our target of 552 women to be randomised. We randomised 32 in the pilot trial, which took place between May and October 2025, and that was over 4 centres, 4 pilot centres, including Grampian. And to date, we've now randomised 77 women across 10 centres that are open. When we did some analysis on the pilot data, you can see just some of the demographics there. So most women had a stage 2 prolapse, 62% of them. 62% also were older than 52 or older, and the mean age was 56. And you can see on the right-hand side the centres that are currently involved in this study, and the asterisk ones are those that are open at the moment. So on to the challenges now. I'd be interested to hear from other people involved in this type of trial work at the moment. We are behind target with our recruitment. We were slower to get off the ground really with recruitment because of delays in approvals, and particularly now we've still got quite a lot of delays with local approvals, with some centres taking 3, 4, 5 months or more to actually get those approvals through so that we can start. And then when the centres have started recruiting, when they've been opened, they're quite slow to get off the ground and to get into the swing of things. The trial has got some logistical things that need to be worked out at centres, sort of coordination of the different elements of the intervention. So the pelvic floor muscle training, sometimes the physiotherapists delivering that are in different location to, for example, where the PessarY clinics are located. So there are those kind of logistics to sort out when centres get started, and I think that can take a bit of time to bed in. I think we're finding that the monthly recruitment is lower than expected also, and I feel that that's probably mostly to do with a capacity issue within the physiotherapy teams. It's not for lack of women with prolapse, but I think because the physiotherapy services are very overloaded, they find they have to kind of keep an eye on the recruitment and the bringing women into the trial because of the capacity they need to be able to commit to those women in the trial and the follow-up appointments. So it's kind of not rushing at it and let's get every woman in we possibly can, because they really have to sort of keep on top of the services, and usually they have quite significantly long waiting lists. So these have been, I think, the things that we've been challenged with at the moment. We have got an informal review by NIHR, the funder, in April 2026. So we'll be reporting to them and getting letters from the TSC and the DMEC at that point as well. We've intimated that we'll be looking for an extension to the recruitment duration and the number of centres. So that's currently where we're at, and the challenges we'll have over the next period of time. The centres are very enthusiastic. Women on the whole are very enthusiastic about taking part, so I don't think it's the lack of enthusiasm. It's just, I think we're in a situation at the moment where research is very difficult to do in this climate we have in the NHS. So I think I'll finish there. if you've got any questions, please do just shout. If you've got any suggestions in terms of recruitment, or you want to share any of your experiences, I would be delighted to hear. And I will just stop sharing so I can see any hands.
Thank you very much indeed. We'll give people a minute or two to come up with any questions. It's great to hear about another ambitious study going on with multiple units taking part already. Prof. Critchley, do come in. Thank you.
Can you hear me okay?
Yes,
you
perfect.
can.
Yeah.
So first of all, thank you. A really clear description of what is a clearly really important study, which I wish you the best of luck with, and I totally understand the challenges that you've shared. So just to, I mean, they're reflections, and I don't know whether as a community and who the group has the ear of, but the delays in local approvals is just such a long-standing issue, and somewhere we need to try and, whatever our trial is addressing, wherever it's being conducted, we have to somehow create a faster approval. And I was very struck and deeply disappointed to hear, which I know is, a reality, that research is not easy in the current climate in the NHS. I mean, we know how research improves outcome for patients. And so how do we, and I don't know whether there's an easy answer here, but how do we create a greater awareness of just how important research is in the NHS? Because this will, in the longer run, hopefully provide economic and certainly enhance patient satisfaction benefit. So thank you again, Suzanne. I think it's such an important study. Again, one of these under-researched, under-recognised areas, but the challenges you share, whether we're in trials or about to embark on trials, we know some of these road bumps are shared across the sector.
I definitely would say that, having done a number of trials now, and there's always challenges, but it feels quite different this time. And with trials, you've got a lot of goodwill with centres that you worked with over the years, but it's just almost seems impossible for a lot of centres. And in some ways I feel guilty that I'm trying to deal with this particular trial and get round problems, and there is this, as you say, this bigger issue, bigger problem that maybe we as individual trialists are tackling, apart from feeding back to the funders and doing all that good stuff. You do feel that there's something critical that needs to be sort of helped or corrected. Yeah.
Thank you. So I think the network itself, I guess, is also a good place to be having these conversations, because it has that ability to feed back, and I guess the R&D heads, etc., will all be keen to know when slow processes for approvals ultimately might end up impacting on whether trials actually proceed or not. So I think this is a good forum to be having those conversations and making people aware. And I guess it's probably one of the many roles that the clinical lead for the network would have on their radar, and very much on their agenda for addressing. So we'll come back to that post again at the end. Any other questions for Prof. Hagen just now? I was interested in your, you mentioned about the challenges of physiotherapists being on a different site from PessarY clinics, was that right? So that you had to have the two things kind of coinciding. And I wondered, was that the kind of thing that had been anticipated as part of the process evaluation, thinking about future implementation?
Yeah, I think it was certainly something we were aware of before we started with we did the trial feasibility, that in some places the physiotherapists are already trained to fit PessarY, so that could be very streamlined.
Yeah.
But at the other extreme, it could be different services, different hospitals, even. And it'll definitely be something that will be really interesting to look into from the qualitative data that we'll have lots of from both the centres and from the women themselves, to see what impact that has had. Yeah,
absolutely. I guess it's especially important, obviously, if there's positive findings
yes.
for the women. So great.
Yes.
Well, thank you very much. I think that's just very nicely brought us to 12:30. So we'll say thanks, Prof. Hagen, and I'll invite Dr. Taylor to come in and tell us about her work on adenomyosis. Thank you.
So thank you so much for the kind introduction and invitation to speak today. I'm delighted to be here. This is a presentation of some of the results of the research I completed for a professional doctorate degree with the University of Dundee, and acknowledgement and special thanks to my supervisors and co-authors Tim, Fiona and Margot as listed here. It's worth saying at the outset that the study's original UK scope was shaped by recruitment, with the final representation being from Scotland and England. I've got no disclosures. I want to get into the findings fairly quickly, but just some brief background. Uterine adenomyosis is a common chronic gynecological condition. We know that it can take several years to be diagnosed, and some of you may have heard and seen BBC journalist Naga Minchetti, who's very active in sharing her lived experience of this condition. Simply put, it's a condition where the lining of the uterus, the endometrium, is found in the wrong location. So it's ectopic, occupying the muscular wall of the uterus, the myometrium. The endometrium responds to the cyclical hormonal effects of menstruation, and there are therefore significant adverse symptoms of it being in the wrong place, as it is with adeno. Most common symptoms are heavy abnormal uterine bleeding, pain, and subfertility. Historically diagnosed post-hysterectomy population burden estimations have been biased to that post-surgical population, but there is now an increasing understanding that the true population burden of adeno is much higher than previously thought. And to give some context around that, in one Italian study in 2024 using ultrasound, 46% of the young women presenting with pelvic pain in that study were found to have evidence of adenomyosis. So this was my research question: how do women in the 21st century living with uterine adenomyosis experience diagnosis in Scotland and England? And to answer that question, some objectives: how are challenges to achieving a diagnosis experienced? How does adeno impact women, and what are the burdens of this condition? And how are women with adeno represented in contemporary government policy and clinical guidelines? The primary question and objectives were developed from the literature review of existing evidence, and we published that review early last year. While existing evidence demonstrates the significant impact of adeno, no prior studies focused on the diagnostic journey. So this research addressed that gap and appears to be the first empirical study to explore how women living with adenomyosis experience diagnosis in Scotland and England. We used a qualitative case study research design. Data sources were semi-structured interviews and documentary analysis with coding, theme development, and I also used some analytical integration via pattern matching process. And Fiona Muir and I published more about this approach in the latter half of last year. Participants were purposefully recruited. They were interviewed between the 8th of January and the 30th of June 2024. Each interview lasted approximately 50 to 90 minutes. All research activity was conducted via Microsoft Teams. The documentary analysis was conducted to examine relevant policies and guidelines that influence the healthcare responses and direct current service provision. And by integrating the lived experience voices with documentary analysis, the design of the study aimed to identify gaps in current practice and hopefully suggest potential areas for improvement in a very patient-centred way. Non-clinical ethical approval was successful with the university school research ethics process. Regarding patient and public involvement, I engaged with support group Endometriosis UK, who provided very valuable advice early on study design, data collection, the appropriateness of the interview questions, recruitment methods, and so on, and participant information, etc. Recruitment, this is just showing some demographics here. The eligibility criteria included women aged 18 or over, residing in the UK, able to consent with a self-declared clinician-confirmed diagnosis of adenomyosis. Participants were excluded if they had any coexisting pelvic malignancy, non-gynecological bleeding disorders, and any other known gynecological or pelvic conditions. Recruitment was passive, participant initiated via social media and online support groups, and this facilitated a recruitment snowball effect. Recruitment attracted in the end 113 women. 71 potential candidates went on to complete screening. 17 responders fulfilled the study criteria. 13 were from England, 3 from Scotland and 1 from Northern Ireland. 10 candidates elected to proceed, and those candidates were interviewed. Of the final 10, 8 lived in England and 2 in Scotland. Age range was 26 to 50 and all were employed. All had undergone ultrasound and 9 had received a confirmed diagnosis via transvaginal ultrasound and 1 via MRI scan. Transcripts were coded inductively. 8 themes were developed, and these themes were clustered around 2 umbrella superordinate themes or domains: impact and diagnosis. 4 themes under impact and 4 under diagnosis. A lot of what this research shows backs up what we already know from the literature, things like the physical, psychological and relationship impacts, the ongoing burdens and the many unmet needs of people living with adeno. But what's new here are the insights into women's experiences of getting a diagnosis, how important a diagnosis is, how hard it can be to access one, the impact of normalising symptoms, and the role of healthcare professional knowledge and receptiveness along the way. And given the time today, I'm going to focus on these novel findings, and unapologetically, I'm going to lean heavily into the women's voices because they're really at the heart of this research. Importance of diagnosis. By the way, any mention I make of names are not real, they are pseudonyms. So without exception, all women spoke of their need to have a diagnosis and the value of this. All participants described feelings of relief, vindication and improved mental well-being, and many voiced feelings of being back in control after having a diagnosis. Although a diagnosis did not directly improve symptoms, it proved clarity to move forward. Diagnosis also enhanced involvement in care and allowed for more informed and patient-centred decision-making. Accessing diagnostic pathways. Women commonly described long and unproductive routes to diagnosis. They emphasised the need to be heard, but felt rarely listened to, often been told it was something they just had to get over. Many felt their symptoms and the impact on their lives was minimised or dismissed, and most emphasised a struggle to be adequately listened to. There was considerable frustration with healthcare professionals, with reference made to missed opportunities, lack of continuity of care, limited meaningful progress. Some women through that became very despondent, feeling that seeking help was futile. Ultrasound referral, pivotal in confirming the diagnosis, was frequently delayed. Some described lengthy trials of hormonal treatment before imaging was considered, and the women I spoke to felt that very frustrating. I listened with some degree of horror as Hope here took matters into her own hands, pulling out her coil by herself, and that was after being told she had another 6 months to persevere with something she felt was making her symptoms worse. Once successful in getting an ultrasound referral, several women unfortunately described multiple unsuccessful ultrasounds over relatively short periods of time. Normalisation of menstrual symptoms emerged as a significant barrier to diagnosis. Women described long-standing messaging from everyone around them, that severe pain and heavy bleeding were simply part of womanhood, being a woman. This dismissal very much discouraged help seeking and eroded confidence. Participants frequently felt minimised or palmed off, commonly told to just get on with it. Such encounters left women confused and unsupported, and Dee here recalled an emergency department consultation where the doctor looked at her in confusion, saying to her, "There's nothing wrong with you, so why are you crying?" This ultimately results in delayed help seeking and reluctance to self-advocate, with women only returning when symptoms became extreme. Women frequently perceived limited awareness of adeno across healthcare settings, especially within primary care. Several participants described inappropriate advice and reassurance that symptoms would, several women talked about being reassured that symptoms would get better once you get pregnant, or pregnancy would probably help. Indeed, Jamie at age 15 was told this by her GP. Although secondary care was viewed as marginally more informed, recognition remained inconsistent. Jamie here describes being completely discharged as normal after their laparoscopy was normal, despite having adeno already reported on an ultrasound, although she didn't know that until a year later. Ultrasound was the main pathway to diagnosis, yet access was delayed and outcomes varied. And unfortunately, many women underwent multiple normal scans before a positive finding. Some attributed eventual diagnosis to a postcode lottery of variable sonographic expertise or reporting practices between different imaging centres. Several women talked of the cumulative toll of repeated invasive internal ultrasound scans, and the word traumatic was commonly used. Despite this variability, a positive ultrasound was a pivotal accelerant in care planning, and once diagnosed, several women acknowledged that progress and treatment started to actually move. Women describe variable experience of receptiveness from healthcare professionals, and some perceived gender disparities, and interestingly, several highlighted that female clinicians were not necessarily more understanding, and they were a bit confused by that. Power imbalances shaped many interactions, and women felt unable to voice their own ideas or suspicions to doctors. Indeed, feeling listened to was very much central to women's perceptions of responsiveness, which tended only to occur after diagnosis. 14 documents from 9 author groups specifically referenced adenomyosis and met inclusion criteria for analysis. These included national women's health strategies and progress reports, clinical guidelines on heavy menstrual bleeding, NICE guidelines, or pelvic pain, imaging practice guidance, and 1 national women's health report. Content across documents was then deductively mapped to the overarching interview domains. In short, the documentary analysis shows very much shows a positive shift in government policy, with both Scotland and England demonstrating a much better understanding of women's health generally and engaging meaningfully with women. But while the direction is welcome, the strategies don't yet offer the practical detail needed to show how this will be achieved in real services, and policy and guidelines around adeno specifically is very poor. This is a busy slide, I know, but just to represent some of the process I went through. I then referenced the 3 analytical sources using the case study, the semi-structured interviews, the literature review, and the documentary analysis to highlight areas where gaps in knowledge may exist and what this research was showing, and if further investigation may be warranted. So I'm very conscious of the time marching on here, so I've just jumped straight to key insights. Delays in recognising uterine adenomyosis persist, driven by symptom normalisation, limited clinical awareness, and inconsistent diagnostic pathways, fragmented diagnostic pathways. Ultrasound is very much central to diagnosis, but frequently mistrusted, with differences in expertise and reporting contributing to diagnostic uncertainty and fragmented care. Diagnosis confirmation was highly valued, offering women clinical validation, personal relief, and a foundation for more informed future considerations and better shared decision-making on treatment options. System-level reform is certainly needed, including dedicated guidelines, strengthened interprofessional collaboration in education, and coordinated care model to support timely, equitable diagnosis. And these findings do align with the growing international shift towards clearer diagnostic pathways and more coherent standardised guideline development. Some strengths and limitations, just very briefly. Methodological triangulation, transparent coding, a use of process of peer debriefing, and integration with policy and guidance. Limitations including bias due to social media sampling. There was an absence of disaggregation by ethnicity and gender identity. I most certainly don't claim generalizability, but transferability, I would suggest, is supported by the thick description achieved through the interview process. The study did not collect healthcare professional perspectives, and this is the future work that is needed to explore diagnostic barriers from people such as GPs, sonographers, and gynecologists. Some of my references, and thank you. And if you want to know a little bit more about my research, you can access via this QR code, which will take you to the e-poster that I did for the Edinburgh Research Conference in October last year. Thank you very much.
Great, thank you very much indeed. That's great to hear. It's a lovely example of a doctoral project as well, and a few different methods adopted in there, which is good to see, and might also inspire other people thinking of doing similar work. I'm just going to check for any questions in the Q&A, but if not, people can put their hands up. Go ahead, Prof. Critchley, thank you.
Well, thank you. Sorry for not using the Q&A, but sometimes it's easier just to ask a question, and congratulate Margaret on a terrific, really important, and I think very impactful piece of work. And it's pieces of work like this that, if you like, provide evidence, particularly as it comes from those with lived experience, that needs to be heard. As you say, we're at a time where the conversation, both the Women's Health Strategy in England and the Women's Health Plan in Scotland are trying to highlight the very things you're demonstrating, you know, this absolute critical area of education for all healthcare providers. And, you know, whether that education should even be in schools, and, you know, we certainly need to see it more visible in undergraduate medical school curriculums. But, you know, this incredible still normalization of symptoms and dismissal, which, you know, is hard to believe in the 21st century, but is still clearly so evident. And, you know, I think it's about how do you, Margaret, now plan to move forward and make sure some of this really important data you've acquired with probably, you know, you've probably just shown us a snapshot of it, could contribute to current conversations. And I just wanted to put on your radar that the NIHR has a women's specialty group, and I was on a call yesterday. The co-chairs are Andrew Horn in Edinburgh and Katie Vincent in Oxford. And some of what you shared would resonate really, really well with the conversations there about how to really bring attention to symptoms, debilitating bleeding, debilitating pain, of which, of course, adenomyosis may be one of the underlying causes, but how that, you know, can be actually ideally addressed across the life course. And so this opportunity for, you know, how one could improve a diagnostic pathway would be really valuable. So I'm hoping that, you know, you might even reach out to, you know, Andrew Horn, based in Edinburgh in Scotland, I think would be really interested to, if he hasn't already, and, you know, I don't want to put, you know, I don't know whether Andrew's read it or not, but I think those, the data you shared, it just really, because they just prove the point of what we're trying to raise the conversation and awareness about. And it all starts with how we educate. And on the ultrasound element, and of course, you know, with radiography being a background here, is that there now are, at least there are published agreed ultrasound criteria for adenomyosis. And in a pathway, you know, could that not be possible to introduce that, you know, those attending gynecology for a pelvic ultrasound, these are proactively looked for rather than reactively found? So sorry if I've talked too long, but I care deeply about this area, and I'd love to talk to Margaret further, because it's really important. And, you know, this area of adenomyosis is just so poorly understood, and it is an entity in its own right. It may coexist with endometriosis, it may coexist with fibroids, but it is an entity in its own right. Well done, Margaret.
Thank you so much, Professor Critchley. So there's a lot in there, isn't there? So as far as my next moves, that's a really good question, because my substantive post is actually not in research, so I'm a clinical practitioner. So it is a little bit of a crossroads for me. But that aside, I will reach out to Andrew Horn, who I have spoken to in the design phase. I actually spoke to Andrew and Varsha in Edinburgh around what I was intending to do, and they were very supportive. So I will reach out to Andrew Horn. One of the things I am trying to do at the moment is get the results published. So I've had one desk reject, unfortunately, but I'll keep going and try and get that published, the results published. Your point about adenomyosis being an entity in its own right is so true, and women told me that, and I think there was several women who were so fed up about being pushed down an endometriosis route. Now we know that the two conditions can coexist, but it is a condition in its own right, and they found it quite frustrating that they were that kept being lumped, if you like, maybe that's a bit of a flippant term, but with endometriosis as a whole, they didn't feel that their needs and their voices were being heard or listened to. So that is a really interesting observation that you make, and I don't know if there was any other questions in there, sorry.
Thanks
but
very
thank
much.
you.
We've just got a minute or so left. I don't think I'm seeing another question in the chat. I suppose one of the things I was wondering about has been partly answered by Prof. Critchley, actually, but it was to do with the radiological diagnosis and whether we have a problem with like skill set and awareness of those criteria in practice.
Yeah, so that's a really important point you make around so the MUSA consensus around ultrasound diagnosis of adenomyosis is well understood, but not fully implemented, I would say, or there's variations in implementation and understanding of how to implement. And the other thing that comes into this is so it's all very well for a sonographer, for example, to say, this is my report, I believe this patient has adenomyosis, for example. Often the GP doesn't know what to do with that. So they may just automatically refer into secondary care gynecological services and that is debate, you know, is there a need for that? Surely they can potentially early on at least be managed in the community. So there's, I suppose what I'm trying to say is there's a lot of confusion and differences and different practices and the way that women are dealt with, and we need that diagnostic pathway from community right through where they go, at what stage, for it, what indications, and there needs to be confidence in the ultrasound, and the ultrasound community, the sonographic community, the radiography community have to be confident in what they're doing as well, because there's a lot of unconfident sonographers out there, scared almost, oh golly, I think it's this, but you know, so there's a lot of education that's needed around there as well in radiographic communities.
Okay, well, thank you very much. I think there's a couple of questions that I might leave you to have a wee read through, Dr. Taylor, if that's okay, because we've just passed our finish up time. And I just wanted to thank everybody for joining and just remind you of our advert that's out at the moment for the next chair of the Reproductive Health and Childbirth Specialty Group. And I understand our next webinar is going to be on the 17th of June, so the details will be shared about that in due course. Thank you very much to both of our speakers and to all of you for joining. Goodbye.